Good morning and good afternoon. My name is Kristen Talbot. I am the Program Manager of MAVEN Project, and I welcome you to today's session on nails, a dermatological approach, a session from the partnership of MAVEN Project and Direct Relief. It is my pleasure to introduce today's speaker, Dr. Ginette Okoye, who is a professor and chair of dermatology at Howard University College of Medicine. Dr. Okoye, when you're ready, please begin.
Thank you, Kristen. Thank you for having me. I'm seeing everyone in the chat letting us know where they are. Always fun to know where people are from. Community of Hope in DC, great to see you. And I see that someone from Cornell Scott Hill Health is here, and I trained at Yale, so very familiar with that area. So welcome, everybody. So today we're going to be talking about nails, and Kristen and I were commiserating earlier that you don't get to hear much about nails usually. So hopefully this will be a fun and interesting lecture for you. And feel free to take a look at your own nails as we go along, because we're going to be talking a little bit about the anatomy in the beginning. And it'll be helpful for you to orient using your own hands. These are my disclosures. And you heard Kristen talk about your CME. All right, so what we'll be doing in the next hour or so is we'll talk a little bit about the basic anatomy of the nail, called the nail unit or the nail apparatus. And then we'll talk about an approach to looking at the nails and examining the different parts of the nails when you're thinking about signs of systemic disease. And then we'll go through some of those signs as well. So why do we have nails? I mean, they're actually pretty important. It's a protective mechanism for the distal part of your finger. It's a mechanical tool that helps you pick up smaller objects. It actually even enhances our sense of touch. And it contributes to our aesthetic appearance just by itself, but then some of us choose to use it to enhance our aesthetic appearance by, using nail polish and little jewels and even adding more nails to increase the length. So it's a pretty important little organ. And disruption of the nail unit can cause a lot of disability, not usually mortality, but it can cause a lot of morbidity. As you can imagine, if you walked around with nails that look like this, and this is a patient with nail psoriasis, you can imagine if you need to shake someone's hand, or if I have patients who are servers in restaurants and they have nail psoriasis, and you're handing someone their food and they're looking at your nail and perhaps wondering if what's on there is contagious. You can imagine how this could really get in the way of people's lives. And so it is part of the skin exam. It's something that we look at in the dermatology clinic all the time. And hopefully by the end of this lecture, you'll have sort of a framework to look at patients' nails in the future. It's a quick exam. And sometimes there are things that are so glaring on the nail that it's going to give you clues as to what's going on with the patient. So let's look at the anatomy for a little bit. This is a cross-section of a finger, and you can see here, this is the nail plate. This is the part of the nail that you can see and feel, the hard keratinized nail plate. Under the nail plate is the nail bed, and the nail bed goes all the way under the nail plate, and it's contiguous with an area called the nail matrix. And so the nail matrix is where the nail comes from. That's where the nail is generated. And the nail matrix can be actually seen through your nail in this area here called the lunula, which is a moon-shaped, kind of crescent-shaped structure that you can see usually on the thumb. In adults, you don't usually see it on all the fingers, but hopefully if you're looking at your thumb right now, you can see a crescent-shaped, lighter colored structure. That's the top of the matrix. Certainly, anything that damages the matrix of the nail will change the contour, the shape, the surface of the nail, because that's the master program. Another important structure to think about when you're looking at nails is something called the proximal nail fold. That's basically the skin that's abutting the nail. Some nail diseases will affect the proximal nail fold, and some proximal nail fold diseases will affect the nail. And then you always hear people talking about the cuticle, especially when it comes to manicures and so on. The cuticle is basically a keratin sheet, a very thin sheet of keratin that goes along the nail, and then under the proximal nail fold, like in this sort of shape, like a V shape, and it makes a watertight seal between the nail and the skin of the proximal nail fold, and therefore the matrix. So it's a super important structure. And this is just another way to look at the nail in a more realistic fashion. Again, you can see the nail plate here, and the nail plate is translucent, so you can visualize the nail bed under the nail plate. So if there are issues in the nail bed, you could see them through the nail. Here's that lunula we were just talking about. This is the proximal nail fold, right? The skin that's right abutting the nail. I thought this was a nice picture of what the cuticle really is. It's this really thin sheet that's going from here all the way down to the proximal nail fold and wrapping under the proximal nail fold. And, as I mentioned, it's a quick exam and nails can tell you a lot. It can tell a story. There is a subset of dermatologists who are nail experts. And as much of a skin nerd as I am, they are nail nerds. Like, this is what they do and think about all the time. And they can look at your nails and tell you like your whole life story. It's pretty cool. But this one is a easier one for someone like me. If I see a patient with nails like this, I'm looking at a couple of things. I'm looking at the shape of the nail, the curvature of the nail. I'm looking at the color, and the skin around it looks pretty normal. But two things catch my eye in this patient. So here's your lunula, right? And then above the lunula is this red flare. That's, if you look at your own nail, that shouldn't be there. And that red flare is, which I just highlighted there, that we call that a red lunula. The other thing I'm noticing is this line here in the nail. That line, if you feel it, it's like a divot in the nail, and that's called a Bowes line. And what that tells me is something happened to this patient. And the nails, by the way, grow at a rate of about 1 to 3 millimeters per month. So I can measure from the proximal nail fold to this Bowes line, and let's say it's 6 or 7 millimeters. I know that 6 months ago, something happened to this patient that was so significant that their body decided that they didn't need to make much nail. They needed to save their life. Maybe it was COVID. Maybe it was a heart attack. Maybe it was pneumonia. Maybe it was chemotherapy, right? So I know that something happened to this patient 6 months ago. And then this red lunula only happens in a couple of cases: carbon monoxide poisoning and heart failure. So if I had to guess, I would say this patient had an acute MI 6 months ago, and now they have CHF because of that. That's how much you can tell from somebody's nail. Looking at this nail, I know exactly what this patient has. They have nail pits, multiple pits throughout the nail, and the pits are not arranged in any specific order. And they have this lifting up of the nail plate, the distal edge of the nail plate, this sort of separation of the nail plate from the nail bed, and that's called onycholysis. So onycholysis and nail pitting, this is nail psoriasis. And this comes in really handy. Sometimes you're looking at really subtle psoriasis on the skin. You're not sure, is this psoriasis? Is this eczema? Is this what you're not sure. It's not obvious cutaneous psoriasis. The first thing we'll do is look at their nails, and if they have pits on their nails, it's psoriasis. It's that good of a sign. The reason I specifically said, the nail pits are in a disorganized way in this patient, because if the pits are in an organized fashion, almost like a grid, then that patient usually has alopecia areata, which is an autoimmune type of hair loss. So a different story, but literally the way the pits are arranged on the nail can tell you a story as well. Okay, so how do I approach examining the nail when I'm thinking about systemic disease? So the first thing I'm looking at is the color of the nail plate. I'm looking at the shape, meaning the curvature, and I'll explain what I mean by that, of the nail. I'm looking at the proximal nail fold. So I want to know what's going on in that surrounding skin. We're not going to spend a lot of time, any time really today, talking about the proximal nail fold, but know that the way that the blood vessels are arranged in the proximal nail fold can give you a lot of clues. If you look at a patient's finger and the capillaries in the proximal nail fold are even visible to your naked eye, that is a problem. It usually means they have connective tissue disease, lupus, dermatomyositis, scleroderma, one of them. So that's a really good sign. The color of the lunula, we talked about a little bit today. A red lunula can signify congestive heart failure. And I look at the texture of the nail plate itself. Are there ridges? Is it crumbly? Are there splits in the nail? And then you look through the nail at the nail bed to see if there are any changes there. So that's sort of a stepwise way that I look at the nail. So that starts with color. So in general, the nail is translucent, but in people who have a lot of pigment in their skin, they can have pigment in their nail matrix, which means that their nail can have pigment as well. So this patient here with brown skin has brownish nails. Sometimes people with brown skin will have nails that are a little bit gray. That is all fine, normal variation if all of the nails are affected in a similar way. If only one nail has pigment on it, that's a different story, and we'll talk about that. This is not a normal color for the nail. Yellow nails should make you think of two things. One is onychomycosis, which is nail fungus, but the other is this condition called yellow nail syndrome. The difference, if you're looking at a yellow nail, the difference between nail fungus and yellow nail syndrome is how smooth and translucent the nail continues to be in yellow nail syndrome, whereas in nail fungus, the nail does not look smooth like this. It gets really crumbly, and I'll show you pictures of that too. Yellow nail syndrome isn't that common, but it can be really impactful if you can identify it based on a nail exam. We're not really sure what causes it, but it's likely related to lymphatic dysfunction. And so patients have these yellowish nails that are still smooth and translucent. They grow very slowly. They lose the cuticle, and the nails are pretty thick and they're over curved. They're too curved. They're almost they're lifting off the nail bed to some extent. These patients also tend to have lymphedema, especially of the lower legs, and they tend to have chronic pulmonary disease. So chronic bronchitis, chronic sinusitis, pleural effusions, bronchiectasis. Those are the four most common associations with yellow nail syndrome. I've had 3 patients with yellow nail syndrome over my career. 2 had chronic bronchitis and 1 had chronic pleural effusions. When they treated, sorry, 1 had chronic bronchitis, 1 had chronic sinusitis, and 1 had pleural effusions. The patient with the chronic sinusitis had surgery and treatment for the sinusitis, and the nails actually improved. But the other 2, chronic bronchitis and the pleural effusions, even with treatment, their nails continue to look the same, unfortunately. But at least it forced us to go down this pulmonary path to make sure that they were evaluated and treated for their lung disease. Anecdotally, you can use high doses of vitamin E for yellow nail syndrome. All 3 of the patients I mentioned, I tried it on. I'm not sure how much that actually works. I think you just have to treat the systemic disease that's causing the nail change. Another color you could see on the nail is brown or black, and sometimes that's okay, right? We talked about the fact that if all of your nails are some variation of a shade of brown or gray and you have pigment in your skin, that is a normal variation. The same is true for a line, a dark line on the nail, which is called melanonychia. If you have multiple lines on one nail, if you have lines on multiple nails, and you have pigment in your skin, that could be a normal finding. Generally, if you don't have a lot of pigment in your skin, so our white patients, I would not expect them to have melanonychia. That would be a signal to me that their matrix is there's pigment in their matrix. Either they have a nevus or a mole in their matrix, or they have a melanoma in their matrix. Melanomas can happen in people of African descent, and so we don't want to ignore those lines in people of African descent. But I will show you some of the worrisome signs to look for when you're trying to decide, is this something I should worry about or not? Again, I just wanted to show you this to remind you that, it can be normal. See how this patient has multiple lines on one nail and then multiple nails with the brown or black color. That's okay. You'll find if you start looking at toenails as well, that many people, especially people with brown skin, that fifth toe gets pretty dark. And that's just from trauma. It's just from chronic trauma in a shoe causing hyperpigmentation of the nail. That's the most common cause of black nails or melanonychia. During pregnancy, melanin sort of wakes up in pregnancy. People with brown skin can get a linea, I think it's called a linea nigra, which is the line that goes down the midline of the body onto the belly. It's the same kind of function where the melanocytes wake up a little bit, and that can happen in the nails. Radiation therapy can cause dark coloration of the nails, and then certain medications. AZT, which is one of those much older drugs for HIV, was a big culprit for this, so we don't see it very often anymore. But minocycline, which we use quite a bit in dermatology, can cause hyperpigmentation of the nails as well. So when should you worry when you see someone with dark lines on their nail? If there's someone with really light skin, so a Caucasian person or a very light skinned person from any ethnicity, right? So they don't have a lot of what we call constitutive pigment. They don't have a lot of pigment in general. If they get a brand new band on their nail, I would start looking at that pretty carefully, especially if they're over the age of 40. Because you can get new moles on your body until the age of 40, and we don't blink an eye. So you can get a new mole in your nail matrix. But after 40, you shouldn't be making new moles on your body or your nails, and definitely not after 60. If there's any change in a band that was already present, did it get darker? Did it get wider? Is the border looking funny? And very importantly, does the color move from the nail onto the proximal nail fold? That is called Hutchinson's sign and is a very good sign for melanoma. This pigment that's in the nail should stay in the nail. It should never involve the skin. So here it is. These are all patients. All 8 of these are patients with melanoma of the nail unit. Here the proximal nail fold is involved. Here the nail bed is involved. In this person, it moves from the nail onto the tip of the finger. Similarly here and here, that bad sign. If the nail plate itself has been disrupted, now don't look at these very nice circles here. These are biopsies. Okay, that's for patient 1 and patient 4. Those are biopsies. Think like this nail, number 2. You see how the nail plate is jagged, it's disrupted. Here again, this patient, the nail plate is starting to be disrupted. If that occurs together with a longitudinal melanonychia, that's also concerning because again, something is going on in the matrix that maybe it's a tumor in the matrix that's disrupting the matrix's ability to create that nail in a regular fashion. If the band is greater than 3 millimeters, I would worry about that as well. And if only a single digit is involved, especially the thumb or the great toe. I highlighted the great toe because that is the most common location of melanoma in the nail. And of course, if they have a family history or a personal history of melanoma otherwise, then we know that they're at risk in general. And melanoma on the nail and the foot, it's a very specific type of melanoma. It's called acral lentiginous melanoma. And it's actually one of the types of melanoma that has the poorest prognosis in everyone, but it has an even poorer prognosis in people with pigmented skin. It's the most common type of melanoma in people with pigmented skin. And part of the reason the prognosis is poor is because it's usually diagnosed too late. And so just being able to recognize this change under the nail and around the nail early, you can literally save a patient's toe, you can save their foot, or you can save their life, because that's the order in which they will lose if we get to this too late. Okay, so another color that you could see on the nail is white. And so there are two ways that a white color can appear on the nail. The first is, and the technical term for a white nail is called leukonychia. So you can have true leukonychia, where the nail is actually white, or you can have apparent leukonychia, where it looks white, but the nail isn't white, it's the nail bed that's white. Okay, so in true leukonychia, the nail, there's an issue with the matrix, and so the nail is not coming out properly. But in apparent leukonychia, the nail is fine, but something is going on in the nail bed, and so it's just coming up through, you're seeing it through the nail as these white bands. So let's go through the forms of true leukonychia. This one is super common. It's called punctate leukonychia. It's much more common in children than adults. It doesn't mean anything except perhaps you traumatized your hand and you had no idea that you did it. When I was growing up, like, they would tell us stuff like, oh, you need more calcium, or you had too much calcium, and like all kinds of things people say about these punctate leukonychia, but it doesn't mean anything. It's nothing bad, but it's caused by trauma. And there have been a few reports of people who got near frostbite who developed these as well. Super common in kids and nothing bad. This, on the other hand, is bad. This is true leukonychia that's caused by a type of nail fungus. So the nail appears white, but the discoloration starts back here at the proximal nail fold. This is called proximal white subungual onychomycosis, quite a mouthful, but the key here is that it starts back here. Nail fungus does not start back here. Nail fungus typically starts on the distal portion of the nail, like this one, right? This is your typical appearance of nail fungus. But if it starts back here and it's proximal, that's associated with immunosuppression. You can literally diagnose somebody with HIV by looking at their nail. If you see a nail like this, do an HIV test unless you have another reason to believe that you know why this patient is immunosuppressed. This is a big one. This is one not to miss. And we've certainly diagnosed people with HIV just based on this. Another form of true leukonychia, another way to save somebody's life, is something called a Mies line. And the Mies line is a very reliable sign of arsenic poisoning, whether that's poisoning is on purpose or by an environmental insult. And so it's also seen in some other things, chemotherapy, CHF, Hodgkin's disease. Either way, a Mies line is not a good thing. So this patient, in addition to having this nice Mies line, she also has a Bose line. We talked about the Bose line before. It's the divot in the nail. So here we are again. Here's somebody who maybe 2-3 months ago, maybe she had chemotherapy. Maybe she had surgery for cancer and then got chemotherapy, or maybe she had chemotherapy first and then had surgery for her chemotherapy, so that for her cancer, and maybe during the anesthesia process she had some kind of insult. So the nails really can tell you a story. This patient is not well. So what is a Mies line? So basically, it's just a disruption in the normal growth of the nail matrix during some kind of insult, right? An ICU stay, chemotherapy, as I mentioned, arsenic poisoning. And if you could think of Mies lines as sort of a beginning of a Bose line, which is the divot. So if the insult goes on long enough, you're actually going to have a sink in the nail where the matrix really decided not to make nails for a while. The thing about the Mies line is all the nails are involved, and the line, and it's usually one line, is parallel to the lunula. And the line grows out with the nail, right? Because remember, the issue is in the nail plate itself. So as that nail plate is growing, that Mies line should be moving with the nail. And so you can measure, as I said in the previous example, you can measure the distance from the Mies line to the proximal nail fold, and you can calculate when this person was poisoned, for example. So we have been able to help in forensic cases using the nails in this way. And then the apparent leukonychia, right? So these are the people who the nail is fine, but the issues in the nail bed, and we are just seeing the nail bed through the nail plate here. And this is called Mierke's line. And basically, these patients have multiple transverse bands that are, again, parallel to the lunula, but they're multiple. And this is usually associated with chemotherapy. That's the setting I've seen it in. But hypoalbuminemia is another reason to have these Mierke's lines. Here's another patient with these two transverse bands on the nails. Okay, so that's it for now for the color of the nail plate. I'm going to stop for a second and answer a question. Stephanie asked, can you develop leukonychia from Raynaud syndrome insults? Yes, I believe you can get punctate leukonychia. Remember the little white dots on the nail? Because a cold insult can cause this, and people with Raynaud's they're gonna feel a cold insult sooner than the rest of us because the blood supply to the area it decreases when they get vasoconstriction in the cold. So yes, thank you for that question. Okay, so let's talk about the shape of the nail. There are two shapes that we think about with the nail. One is a spoon nail, where the nail has a spoon shape, basically a curvature in the nail. And then we also think about clubbing. So these are the two shapes that are important for the nails. So here's a nice example of spoon nails, also called koilonychia. And this is pretty reliably related to iron deficiency, as well as hemochromatosis. Either way, you do not want to ignore spoon nails. And sometimes it's only on the thumbs. It doesn't always happen on every single finger. So, and if I see a patient like this, I would check the CBC and I would check a ferritin level as well, because their CBC, the hemoglobin may be 10 or 11, so they don't look terribly anemic to you, but then their ferritin is 5. And that's sort of the setting that I've seen it in. And then clubbing, which I feel like many of us learned in school because it is one of the more common nail signs that we learn about. Basically, patients get enlargement of the soft tissue of the distal finger. And so the nail plate itself enlarges and it gets this really long longitudinal curvature. And so it widens this angle that's usually present. So this red line demonstrates where the nail usually sits in reference to the proximal nail fold, but in clubbing, it gets this long curvature going downwards and increases that angle past 180 degrees. This is a little test. If you're ever wondering if somebody has clubbing, you can have them put their fingertips together like this, and there should be a little diamond shape between the fingers. If you cannot see that diamond shape, it's a nice physical sign that they have clubbing or they're going in that direction. And clubbing is important. It's almost always associated with something. Now, there is a congenital form of clubbing that runs in families. That's different. This is someone who in adulthood develops clubbing. I would, start working them up looking for lung cancer, hepatocellular carcinoma, tuberculosis, HIV, hepatitis C. In the setting that I've seen clubbing, mostly it's pulmonary COPD and lung cancer. Those are the two cases that I worked up and found these diseases. So they are really burned into my brain. But inflammatory bowel disease and hyperthyroidism are also on the list, have been reported with adult onset clubbing. So definitely do a review of systems. If the patient has a tobacco history, then I would be really, really, really suspicious that something's going on. All right, so next, let's talk about the nail plate texture. Let me look, there's a question here. So Catherine is asking a nice question. In terms of nail growth and the signs of trauma, do you assume that this would also slow nail growth overall? I guess you're talking about the Mies line or the Bose line. Um, Not usually. Not usually. I mean, our nails continue to grow even after we die. So I think the nail growth continues. It's just that it's not as robust as it used to be, and then you get that divot or you get the Mies line. Um, there are some conditions like yellow nail syndrome where the nail growth is slowed down. That's part of the disease, but in general, no. Thank you for that question. All right, so let's talk about the nail plate texture. So let's do a couple of cases. So this is your patient. This could be you. This is what my nails look like half the time. So people come in to see us and they're concerned about their nails looking like this. It's a little rough, right? They have some longitudinal ridges. They have splitting. When the nail grows out a little bit, it splits. And, these splits are really vexing. They catch on everything. They catch on your hair, they catch on gauze, they catch on your clothes. You could have these little, multiple splits here. Sometimes you can have peeling of the nail. See how the top, it's almost like the top layer of the nail is peeling back here. Okay, so this patient, she's 60 years old, and she comes to see you with, complaining of thin splitting nails, or she's seeing you for something else, and she says, hey, what do you think of my nails? They're thin, like I can't seem to get them to grow. They grow and they break really easily. She says she doesn't really get manicures, doesn't do anything to her nails that she could tell. She has some hypertension. She takes amlodipine and is otherwise pretty healthy. She doesn't smoke. She does, alcohol socially, and she's an ICU nurse. So this is a really common scenario, by the way. So this is just called brittle nail syndrome. Makes it sound much more serious than it is. But it's pretty vexing to people. It's this fragility of the nail plate that results in splitting of the nail, peeling of the nail, and just overall kind of weakness of the nail. And it's basically due to dryness, right? The lack of hydration of the nail, just in the same way this would happen to your skin. It means that the lipid content of the nail plate has been depleted, and that reduces the ability of the nail to retain water, and then it leads to dehydration. And then once it's dehydrated, it's just easy to be traumatized. And it's the most common cause is frequent hand washing. So it's really common in healthcare workers, people who do wet work for any reason, people who are washing dishes a lot at home, people who are changing babies a lot and washing their hands a lot. And the reason is the surfactants in soap basically strip the nail, just like it strips your skin. It strips the nail of the lipid content and makes it just more vulnerable to every other insult. Frequent manicures can also cause brittle nail syndrome. Sometimes it's the acetone that's being used on the nail, which again takes the lipid layer off. Sometimes in manicures, they'll literally use either a nail file, like an emery board, or they'll use a device and literally thin the nail. They rough up the nail so that like acrylics and so on will stick better. So gels would stick better, and that thins the nail and it gets rid of that protective coat, and the nail loses lipid and water. Same concept. Occupational exposure to solvents, same issue. The solvents strip the nail. So acetone, alcohol, other solvents, if you're in contact with them and you're not wearing gloves, you can get this brittle nail situation. So that's the primary cause and the most common cause. But there's some secondary causes that we have to think about as well. So the first thing I would do with that patient, who I know is an ICU nurse, is probably doing a lot of hand washing, is we would talk about just moisturizing the hands and the nails with a petrolatum-based moisturizer every time she washes her hands, wearing gloves as much as she could. And if that still didn't improve things, then we're starting to go down this road. So brittle nails can absolutely be caused by systemic illness or vitamin and mineral deficiencies. So in terms of the vitamins and minerals that have been implicated, they're listed here: vitamins A to E, selenium, zinc, and iron. And even though we live in the US, I'm sure you guys know with your patient population, people can be overnourished and undernourished at the same time. Like they can have caloric overconsumption, but underconsumption of nutritious food, or restrictive diets that can cause vitamin and mineral deficiencies. So definitely keep that in mind. And in terms of the systemic illnesses that can cause brittle nails, thyroid disease is a big one, hypo or hyper, diabetes, iron deficiency, anemia. Those are the three most common causes. And then some medications, but you would know that the patient is sick. So it would either be chemo or antiretrovirals, but they've been implicated as well. So I think if someone comes in, and this is a great photo here because this is usually what the patients look like, because their hands are dry, their skin is dry as well, as are the nails. So I would still do a good history and physical, right? Just make sure there are no review of systems concerning for any of these systemic diseases. Make sure that they're not having any GI symptoms to suggest that they may be having malabsorption of their vitamins and minerals. Do they have a restrictive diet? That sort of thing. I would still try to get all of that evaluated. And I would look at the rest of their skin. If the rest of their skin, especially their hands, are pretty dry, then you may just be dealing with hand washing frequency, and you can just recommend milder soaps. I have some of them listed here. Moisturizing the hands after hand washing, and then using gloves even when they're home and doing their dishes. They should just, decrease the contact of their hands with soap. And then, you can always consider adding a multivitamin. Patients love biotin. Everybody comes in having already tried biotin, but honestly, the data on the efficacy of biotin improving hair and nails is pretty weak. It does not work for hair. It might work a little bit for nails, but what's probably happening is the person is taking biotin and other B vitamins together. Often biotin will come together with the other B vitamins. So we actually are not sure if it's the biotin or if it's sort of nutrient deficiencies in general. The other caveat with biotin, if you wanted to recommend that, is, it can alter troponin levels, it can alter thyroid function test results. So I always tell patients, if they are taking biotin, to let everybody know, so that if they need these tests, we can know that they're on it, or they can stop it if they have a planned thyroid function test coming up. And I wouldn't just recommend any multivitamin, especially since we know that there are specific vitamins that seem to be involved in brittle nails. Just you want to make sure that it actually contains zinc and selenium, because not all vitamins out there have selenium. But actually you can have one Brazil nut has all the selenium you need per day, by the way. And iron, only if they're iron deficient. So I would give that a check before recommending that they take iron every day. And then depending on the history, I would check the ferritin, the thyroid panel, hepatitis, HIV, depending on their risk factors too. And depending on where you live, where I live in DC, we check hepatitis C and HIV every chance we get, because and RPR for syphilis, because the prevalence is relatively high, and we just don't want to miss it. But we don't know when that patient will see a healthcare provider again, frankly. And then fasting glucose and hemoglobin A1C if you have reason to suspect this patient is diabetic or pre-diabetic. All right, let's do another case. This is our final case. This is a 68-year-old man. He reports many years of yellowing and thickening of the nails. Most of the toenails are involved, including both of his great toenails, and his fingernails are normal. In terms of his health, he has diabetes, he has hyperlipidemia, and he takes metformin and atorvastatin. So the patient comes in saying, look, I have nail fungus, I don't like how it looks, and I want it to be treated. Again, very common scenario in my setting. When we talk about clinical cure of toenail fungus, patients usually mean mycological cure, meaning the fungus is gone from the nail and their nail returns to normal. You It's easier to get mycological cure of the nail. So like you got rid of the fungus, but it's not that easy to get the nail to come back to the way it was. And there were two reasons for this. One, toenails grow very, very slowly, about a millimeter a month if you're lucky. So it takes a year for that nail to grow all the way out. So even if it's better, you still have to wait a year to see the results of that treatment. So I think it's important to set that expectation for patients. And there was a study from about 2 or 3 years ago that really changed the paradigm for me in some ways. Um, Frankly, clinical cure when it comes to toenail fungus may not be possible in some patients. And so I do try to set that expectation. And these are the risk factors listed here for people who may not get a cure. An important one is anything that disrupts the blood supply distally in that area. So poorly controlled diabetes, peripheral vascular disease, immunosuppression, um, any history of nail trauma. So if they, like a runner, for example, if they're a runner and they're constantly traumatizing the nail in their shoes, it just means that that nail is always sort of open and ready for fungus to enter it. And fungus is everywhere, by the way. So if they have nail trauma, chances are you're not going to be able to get rid of it altogether. A really important one is this thing, subungual hyperkeratosis. So under the nail, you get this piling up of tissue that's pretty common in nail fungus. But if that is more than 2 millimeters thick, the chances of getting rid of that nail fungus are really, really slim. And then if more than 50% of the nail surface area is involved, then that also decreases the chances of it getting better. And something called 2-foot, 1-hand syndrome. So people who have nail fungus on the toes and on the fingernails, that is not a good sign either. Doesn't mean I won't treat patients for their toenail fungus, because again, we talked about the quality of life impact of this, but it's just about kind of setting expectations. Often I'll do a fungal culture. It doesn't stop me from starting treatment, but it can help me stop treatment early if the fungal culture comes back negative. Remember, you can have nail psoriasis, you can have lichen planus of the nails, you can have trauma to the nails that looks like fungus, but it actually isn't. So I do a culture. And here are the options for treatment. Terbinafine, 250 milligrams a day for 6 weeks for the fingernails, 12 weeks minimum for the toenails. And then look at the cure rates. For toenails, it's about a 40% cure rate after 12 weeks. And, we used to be worried about terbinafine and liver injury, but I think enough data show that liver injury is extremely rare, and we used to regularly monitor LFTs when people were on terbinafine, but we don't anymore. There are two more options you can use. One is itraconazole, which is a nice dosing because it's pulse dosing. It's 200 milligrams twice a day, just 1 week for each month. And it takes 2 months of treatment for fingernails and 12 weeks, so 3 months of treatment for toenails. And with the toenails, you can't really get away with the pulse dosing. You have to do it 200 milligrams every day for those 12 weeks. The cure rates are a little bit lower than terbinafine. For the toenails, it's like 15%, so not great. And then another option is fluconazole, which is not FDA approved for this, but it's nice because it's just once a week dosing, 150 milligrams once a week for about 9 months for fingernails, for a year and a half for toenails. The only downside of fluconazole, in my opinion, is that it can interact, and itraconazole, they can interact with other medications. And so it depends on what the patient's other medications are. We don't have this option. So in this patient, we did, this is from the literature, but this is thinking of a specific patient. We sent the nail clipping for culture. It actually it came back negative after about 6 weeks. But we counseled this patient on the low chance of clinical cure. If you remember from his history, he had diabetes, more than 50% of his nail plate was involved. He had pretty thick subungual hyperkeratosis here. So, the chances of this working were going to be pretty slim. But we did the terbinafine, 250 milligrams a day, We did not want to do itraconazole or fluconazole because he was on atorvastatin, and these drugs can interact with atorvastatin, increase the levels of atorvastatin, and cause rhabdomyolysis and other bad things. 6 weeks later, when his culture was negative, we called him and he agreed to stop treatment. One, because the chances of it improving were slim, and two, because by then he hadn't seen any improvement yet, which I wouldn't expect much improvement at that point, but patients lose patience with this very, very quickly. So in summary, I think, knowledge of these nail changes could facilitate earlier diagnosis of some systemic diseases, and consider just taking a look at the nails as a routine part of your physical exam. It's super quick, but there are things that you don't want to miss. So if you didn't leave this lecture with anything, I want you to think about these 4 things. If you see a white discoloration on the nail that's proximal here, to the proximal nail fold, think about immunosuppression, think about HIV. If you see brown discoloration of the nail that is greater than 3 millimeters, changing the nail plate itself, and especially if it's extending onto the skin behind the nail or in front of the nail, think melanoma. If you see clubbing, think something's going on in the lungs, lung cancer, COPD, pulmonary hypertension, bad actor here. And then if you see spoon nails or koilonychia, think about iron deficiency anemia and hemochromatosis. And with that, I thank you for your attention and your questions. I see a few questions in the chat, so I'll start working on these.
Thank you, Dr. Okoye. That was fantastic. Just a reminder that your CME survey will appear in a tab on your browser when you close out of this webinar, but I also put it in the chat for your ease. But I'll turn it over to you, Dr. Okoye.
All right, thanks, Kristen. So Kelly is asking, are brittle nails common after bariatric surgery? Yes, 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 yes. For the same reason we talk about those micronutrient deficiencies, we certainly can see that. And now with the GLP-1 agonists, people with like rapid weight loss, and they're just eating less potentially, and they're getting fewer nutrients. Same thing. So yes, common. And usually if someone has brittle nails and it's from a systemic reason, then they're going to have some complaints about their hair as well. So the hair is thinner, it's shedding. Those two go hand in hand. And Jermaine is asking, how do you access for an ingrown toenail and management, and what guidance do you give patients for it not to recur? So Jermaine, I have to admit that podiatrists do a much better job at ingrown toenails than we do. Some dermatologic surgeons will work with ingrown toenails, but honestly, if someone comes to me with an ingrown, I may treat the infection or the paronychia, which is like the infection around the skin that they can get due to the ingrown toenail, but I will refer them to podiatry for usually surgical intervention. And in terms of it not recurring, again, I would defer to my podiatry colleagues, but from what I have been told, when patients are clipping their nails, if they have a tendency to ingrown toenails, they should clip it square at the front and not sort of cut it in this, U shape, which allows the nail to grow into the skin easier. And Stephanie asks, what causes the subungual hyperkeratosis, and how do you help with the subungual hyperkeratosis? It is part and parcel of fungal infection of the nail. I can't say I know for sure why people deposit keratin in that area, but it's also full of fungus there as well. So it maybe it's just honestly, I don't know why it happens. But I don't think there's anything you could do to prevent or decrease subungual hyperkeratosis. It's caused by the fungus itself. So I think treating the fungus early before it gets a chance to get so thick is what makes the difference. And then Karen was asking, what was it if not fungal? But I'm not sure which one you're referring to. Feel free to come off mute, Karen, or you could put it in the chat. In the meantime, Jermaine had another question about with recurrent manicures, how does that impact the nail integrity? So it causes that brittle, it increases your risk of that brittle nail syndrome. So the manicures for a couple of reasons. One is the exposure to acetone, which strips the nail of the natural oils and makes it vulnerable to lose hydration very easily. So that's one reason manicures can impact the integrity of the nail plate itself. Another way manicures can cause issues is if the manicurist is actually using an emery board or one of the they have this rotary tool that basically strips off the top layer of the nail to allow gel manicures or acrylic manicures to adhere better to the nail so it'll last longer. That is literally stripping off the protective layer. And again, the nail will just dry out and be brittle. Another thing is during manicures, if they remove the cuticle and they're removing that nice waterproof barrier that you have between the nail and the skin, which can set patients up for some infections and fungal infections, yeast infections, and so on around the proximal nail fold. All right, let's see. Oh, Karen's saying that she's saying, what is it that patients nail if it's not fungal? Honestly, Karen, it probably is fungal, but if they didn't have enough fungus to sort of to show up in the culture, then what I think we're seeing is this architectural change of the nail secondary to the fungus. But treating the fungus at this point isn't going to change that architectural change of the nail, if that makes sense. But also psoriasis can cause nails that look like this. People can have nail psoriasis alone and have no psoriasis on their body. So could it be psoriasis that we missed? It could be trauma. So people who, especially people if they have neuropathy and they aren't always aware of traumatizing their feet, or their feet are always bumping against ill-fitting shoes, their nails can become thickened in this way. It doesn't usually develop the subungual debris, though. That debris is pretty specific to nail fungus. So I would say this patient has fungus, but that's not what's causing the change that he's seeing at this point. Thank you for that question. And thank you for clarifying. Ben is asking about transverse nail ridges. So Ben, that's probably similar to the longitudinal nail ridges. Because it's transverse, it makes me that would make me more suspicious for a systemic issue or like a nutritional issue, because it means that there's something going on in the matrix periodically where it's not creating as much nail as it wants to. So for transverse ridges, I would probably check out their vitamin status, check out their diet, maybe just put them on a nice multivitamin for a while and see if it improves. And that's the nice thing about nails. You can, within a few months, see if your intervention has improved, because you could just look at the proximal part of the nail and see if it's changed, if it's smoother than the distal part, because it should be growing out normally if your intervention helped. Let's see. So Kelly's asking, does nail polish cause a lack of oxygen to the nail? I don't know. I have wondered myself, because I don't generally get manicures. I'm way too paranoid based on all the stuff I see. But for special occasions, I would go and get like a gel manicure, and invariably, and I tell them, please don't file the nail, don't use your tool, like I'm a nightmare. But even when they haven't done that, when the gel comes off, my nails are thinner. And so I'm like, oh, is it a lack of oxygen or exposure to air? I don't know. Oh, something else that I didn't mention, and someone, I think it was Jermaine's question about the impact of recurrent manicures. When people are doing gel manicures, they're putting their fingers under a UV light to cure the gel. And so, we've been a little bit concerned about the risk of, if every week, every 2 weeks, you're getting this extra UV light to the proximal nail fold and the nail, would that increase your risk of melanoma? There's no data to support that. But I do wonder about that as well. And so Kelly, when patients ask me about whether or not they can apply nail polish, I generally just say, yeah, do whatever you want to do, especially if your nail bothers you, you don't like the way it looks, you want to polish it, that's fine. Just take it off before you come back to see me so I can see what's going on with the nail. Let's see. Jennifer is asking, how do I prefer to drain subungual hematomas? So I don't do a lot of procedures on the nail, Jennifer. However, if I were to drain a subungual hematoma, I would probably do a nail block, a nerve block, by just injecting a little bit of lidocaine on each side of the digit and let that sit for a few minutes just to help with pain control, because boy, the nail bed has a lot of nerve endings. It's excruciating. And then I would use a punch biopsy tool which is a circular knife, and I would just go into the nail over the hematoma and allow it to drain from there, knowing that that nail defect is going to remain, but the circle that you cut, but it'll grow out with the nail eventually. That's one option. I usually send any of these procedures to a derm surgeon. They're just much better equipped than I am to do nail procedures. And let's see. Thank you, Jermaine. Yes, that's a great takeaway from this talk, to think of skin, hair, and nails together and just like make it a habit to check all three. All right, I think I see some stuff in the chat. Let me see. All right. All right, thank you for the feedback, everybody. And yes, you will have access to the slides. I sent them in PDF format. So, okay, I don't think there are any other questions. If I missed your question, please let me know. You all were so engaged. I really appreciated you, being interactive. It makes it that much more fun. Any other questions?
Well, thank you so much, Dr. Okoye. This was fantastic. Thank you all for joining us today, and we'll see you next time.
Bye.